Well, the first thing I always say is there is no such thing as a smoker's cough.
Right.
You should assume that a smoker's cough is something else until you've ruled out every other possibility.
We also assess the severity of shortness of breath by using one of the common instruments. Basically, there's the Modified British Medical Council, MMRC, a 0 to 4, so a 5-point Likert scale ranging from I can't get out of bed to no impairment. That would be one.
When you are considering the diagnosis and undiagnosed component, the symptoms that are present, give us a sense of where you think age plays a role in that.
I'm going to start thinking in the 40s, and I think that's much earlier than a lot of people do. They say, oh, you don't have COPD until you're 60, 70. That's just not true. We want to recognize these. A lot of people go along with symptoms 10, 15 years before somebody figures it out.
I'm 80 years old, and I don't have, hardly, the only thing I have wrong with me is the COPD. I didn't really jump into it too much. I just went once for a test, and that was it. And then you came every year, and I didn't really learn anything about it, other than he was glad that I gave up the smoking. He was glad that I was going, but there was never any discussion about what you could do if you wanted to change it, or at least temporarily change it.
And was there a discussion about what it meant to have COPD?
No.
Well, I'd love them to have pulmonary rehab available because there's just so many benefits from pulmonary rehab. Now, we know it's not always available. So I'm going to have to see what the patient currently does. And then we're going to talk about some simple things. Say they can walk halfway out to the mailbox. I'm going to want them to walk all the way out to the mailbox. I'm going to want them to walk half a block further than they think they can.
I decided that I wanted to take a little bit more charge than the doctor was hearing me, and do my own investigating, and be my own sponsor. And went to a class for 26 weeks, which is part of your Medicare, and did extensive exercises. And when I went, I could only walk 2 blocks, and now I walk 15 to 20 blocks a day.
And I think that is so crucial. It's made a huge difference in your life, hasn't it?
It taught me how to breathe better.
Then you need to go to a long-acting bronchodilator, and you can use what you're most comfortable with, and maybe you'll think about cardiovascular. If patients have had problems with one or the other, you can do the long-acting beta agonist, or you can do the long-acting anticholinergic. And now, what I think you really ought to think about is if you're not getting symptomatic relief like you want from whichever one you chose, you add the other one. Because now they come together in one inhaler. It's not like, oh, I have to fight with the insurance company. I have to convince the patient to use 2. You can use them together.
Now, one of the things I think doctors should really pay attention to is morning and nighttime symptoms.
Key things here.
Because the once-a-day drugs are beginning to fall off. Does that second dosing at 12 hours, the Alvar-Agosti hypothesis, that with a chronic symptomatic disease, do you need to treat it more frequently? That's on the table.
Barbara, when you are a clinician in the primary care setting managing a person with COPD, what do you do?
First, you try to get them to come back in on a regular basis. And when we get them in, I think it's important we show them we're doing something. We're not just saying, well, how you doing today? Oh, fine. Okay, bye. So I like using the CAT now for that reason, because it shows them that I'm asking specific questions, I pay attention to it, and I may do something actionable based on it.